Support for The Nocturnist comes from the California Medical Association.
At The Nocturnist, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
This is The Nocturnist Conversations. I'm Emily Silverman. Today, I'm joined by Dr. Susan Nathan, a palliative care physician at the Boston VA, and Thor Ringler, a therapist, poet, and longtime storyteller at the Madison VA. Together, they lead My Life, My Story, a simple yet revolutionary program that invites veterans to share their life stories in their own words. Volunteers sit down with veterans for in-depth, open-ended interviews, carefully write up their stories in the first person, and then read the narratives back for the veterans' approval. Once finalized, these stories are added to the medical chart, where clinicians can access them and see the person behind the patient. In my conversation with Susan and Thor, we explore how a small idea in Madison grew into a national program across 80 VA sites, the art of deep listening and writing stories that truly reflect a person's voice, and how these narratives are changing the way clinicians see and care for their patients. I hope you enjoyed this conversation as much as I did. But first, let's hear Susan read one of the first-person narratives from the My Life, My Story program. Here's Susan.
I was born in Panama as the second of 6 boys. If you include half-siblings from my father, you would get all the way up to 12 boys and 2 girls. My mother has been a teacher for as long as I can remember, and still, even at 80 years old, she is a teacher. 3 of my brothers came to the United States in the late 80s, and I, along with my 2 remaining brothers, came shortly after them, along with my mother. Initially, we were here on student visas, but quickly obtained green cards. Rather than waiting for the long process of naturalization as a civilian, I decided to join the military. On the day I was naturalized, I was a part of the National Guard and was on the USS Kennedy in Massachusetts. My naturalization card was handed to me by none other than Senator Ted Kennedy. When it came time to celebrate everyone's American citizenship, Senator Kennedy handed me a sword to cut the cake. Shortly before I was scheduled to go to Iraq, a private was carving a stick with a knife as I walked by. It first felt as if someone slapped my hand, but when I looked down to see what had happened, his knife had flown out of his hand and stuck into mine. When I pulled the knife out on instinct, I lacerated 3 tendons. Because of this, I required 3 surgeries and was unable to go to Iraq. When my friends returned, they made fun of me for my lack of combat experience. To show them that I could fight too, I immediately signed up for active duty. I chose to be stationed in Hawaii. Shortly after arriving, I was chosen at random to be assigned to Fort Shafter to serve the general as his driver. I think the branch forgot that I existed because I ended up staying there for 6 years. Unfortunately, while in Hawaii, I had a very challenging experience with a sergeant that has shaped much of my life since. The sergeant made my life a living hell and put me on his list of bad soldiers that he sent to the oncoming captain. Since I was labeled a bad soldier, I was constantly berated and treated poorly. Unfortunately, due to a miscommunication with my sergeant, I quickly found myself in even more trouble. When I tried to explain to the platoon leader what had happened, my sergeant and captain overheard my conversation and said I would be fired from the Army for disrespecting them. For the next several months, I was constantly walking on eggshells. I was so overcome by the stress and anxiety of the situation that I became suicidal. When I went to seek help from the military therapist on the base, my problems were dismissed because I had never been in combat. I vowed to myself at that time that I would become a therapist and would make sure that when a person sought help, they would find it. This promise to myself helped me make it through this time in my life. My first experience as a therapist was while I was still in the Army. During my later years in Hawaii, I was a manager of other soldiers and also acted as a counselor. Whenever new soldiers arrived, I told them, "We come from all over the world with so many different backgrounds, but we all need help sometimes." I remember one night a female soldier came to me to talk. She told me that she had been sexually assaulted by a higher-ranking official. When she tried to tell others about her experience, she was dismissed. She told me she wanted to commit suicide that night, but she would give me a chance to listen. I told her this could not stand, and as a mandatory reporter, I had to tell others about her situation. I called everyone I knew in a position of authority and shared her story to initiate an investigation. The perpetrator, as well as everyone involved in covering up this assault, were either sent to prison or dishonorably discharged. That soldier is one of my very best friends to this day. Once I left the military, I studied psychology. As a Black bilingual man, I knew how valuable I could be. I knew how much it meant to talk to someone who looked like you and spoke your language. I've been able to work with many people, including those struggling with addiction in Boston. To all of my patients, I share the same core insights that I acquired during my time in the military and through my own experience with trauma and mental illness. I ask them to imagine an apple on the table between us, with one rotten side and one side that is shiny and red. Depending on how I place that apple on the table, they may see the beauty in life, or they may only see the hardship. In reality, life has plenty of both, beauty and hardship. The only way we see both halves and see life for what it really is by connecting deeply with others and seeing the world from many perspectives. I've noticed that men especially don't always seek out that help and don't want to share their trauma. I make it my mission to help them open up, and in doing so, move forward with their lives. I'm so lucky to now have 6 children who I am incredibly proud of. Among these include a daughter who loves to paint, like me, and who is going to school to be an artist, and a son who is training to be a therapist. I also have 5 grandchildren and another one on the way.
Thank you, Susan, for that reading. I am sitting here with Dr. Susan Nathan and Thor Ringler. Susan and Thor, thank you so much for coming on the show.
Thank you.
So I'm still letting your reading sink in. I have to admit, I got very sucked in, and now I'm just kind of processing that. But let's start with the two of you. Tell us, each of you, about your individual backgrounds and how you got into medicine and storytelling.
You're pointing at me, Susan.
Yeah, Thor, why don't you go first?
Okay. Yeah, very circuitously. I've been a person with a lot of different careers, different jobs over my life. I initially thought I was going to be a teacher. I wanted to teach poetry, so I got an MFA in poetry. That was my first higher degree after bachelor's. Tried teaching for like 4 or 5 years to realize I wasn't a teacher. And then just sort of floated around doing IT stuff for quite some time, like 15 years. I was doing web development, web programming. Decided I wanted to do something that had more of a impact on people directly. So I decided to go back and get a degree in marriage and family therapy. And that's actually what brought me to the VA. During that internship year, I worked at a vet center, which is a part of the VA. It's a counseling center for combat veterans, separate from the VA hospitals, and they only provide therapy and counseling. Not being a vet myself, not coming from a military background, I was actually a little frightened about it. And honestly, I was like, oh my gosh, scary military people. What are they like? And of course, I was amazingly surprised, or pleasantly, at how much I loved it, how much I loved the vets I talked to, and was determined to work at the VA after that. And then this job came up kind of randomly in Madison, where I live, and someone who had been at the vet center who worked there sent me this job posting they were looking for writers who were therapists who would interview people and write up their stories. And I was like, oh, wow, that job is made for me. So I had just started another job 2 weeks earlier, and I quit it. It was like a full-time, permanent thing at the university here. And I quit that for a 6-month pilot.
How about you, Susan?
I'm a palliative care attending, and I'm also a geriatrician, and I'm also with the internal medicine base, and I run My Life, My Story here. But part of what drew me to geriatrics to begin with was that I always just had more fun talking to my older adult patients. I found them more interesting and often had a more pragmatic approach to basically everything relating to healthcare. And in contrast to some of the general internal medicine for my geriatrics patients, There was no checklist that would cover them because then they'd be on 50 medicines that all had counteracting side effects. So a lot of creativity.
Yeah.
So I always like creative problem solving. I love working in a team. And then I had somehow never done any VA rotations in all of my programs. We just weren't affiliated. And so kind of similar like Thor, I was very new here and I had a patient. He was in the hospice unit. He was dying. He couldn't talk. Family was not really accessible. And I just stumbled, you're looking through the chart and I just wanted to know, who are you before today? I read and I read and I read and I read and a lot of notes. And I just stumbled on this, which was his story, his words, just like the story I read from 3 or 4 months before. And it just obviously told such a different story. And while the facts that I had were accurate, there was no context. And so I think a lot of my medical training, especially, internal medicine residency and chief residency and such, I work with first-year medical students. It's always, summarize. What's the chief complaint? What's the one-liner? We're making a list. We're reducing. And in contrast to geriatrics and certainly palliative care, where we're trying to re-expand, go back, beyond the list. And then I just saw this story and they're short. So it probably took me 1 or 2 minutes really to read it. And it just changed kind of everything. And then we just started doing it here. I didn't even know that this was a project. It was months later that a colleague said, "Oh, I think this is a VA program." And literally maybe 6 months later, I emailed Thor. He was like, "Yes, this is an established program." And then it just went from there.
Tell us about the origins of the program. How did it get started and whose idea was it and where did it come from?
It was originally a project by a resident psychiatrist at the Madison VA, and he worked with his supervising clinicians there. And one of the ideas that he had was it sure would be nice for psychiatrists to be able to remember who their patients were, since they have 1,000 people on their panels and they see them for 30 minutes and there are a lot of folks who have similar backgrounds. So that was sort of the genesis of the project. They initially tried doing a PowerPoint kind of list of the things that people liked, their favorite ice cream, their favorite color, what kind of dog they had. They found that didn't really help them remember the person very well. The second iteration was having people write their own stories, having veterans write their own stories, and that was successful for the 1% of veterans who were interested in doing it. And then they stumbled on the idea of let's just see, what if we got some people who are writers to do these interview people about their lives, write up the stories, and then have that be the item that would be in the chart. And so that's when I came on with the project. So it wasn't my idea, but I think what I brought to it, my sensibility was just that it should definitely be completely patient-centered and it should be in their voice and they should get to review it, and it could never go in the chart without them reviewing it and basically giving them sort of implicit ownership of it. Like it wasn't ours, it's theirs. Those were core things for me.
I love what you said that initially the idea was let's have the veterans write their own stories, and then the barriers to that, because some of them may not consider themselves writers or may not be interested in putting pen to paper or typing. But having writers come in and sit down and interview the patient with that openness and that curiosity, almost like a journalist, and then going and writing it up, it's a brilliant model. And I'm wondering, who are the writers typically, and how do you recruit them into the program?
Oh, I'll turn over to Susan here for the writers at Boston, because it actually varies from VA to VA.
So in Boston, we're a little bit different in that the vast majority of our writers are our trainees who are rotating with us. So anywhere from pharmacy students, PT students, residents, speech, language, pathology, nursing, nurse practitioners, geriatric fellows, palliative fellows. And so we've just built it in to their activities that they're already doing, because what we're trying to say is that this is routine care, being curious, listening non-judgmentally, making sense of complex, nuanced, nonlinear information, and also writing clearly. These are all core skills. So almost 2,000 trainees have participated in this at VA Boston, just as part of their routine rotations. But it's a little different than in Thor. Maybe you can talk about the other writers.
Sure. So at Madison, it's more based on volunteering. So we have community volunteers who reach out to us who are writers, interested in writing, also really particularly interested in using their particular skill set in a volunteering role. And so there's actually some very talented people out there who want to volunteer, but there's not many places you can volunteer as a writer and actually use your writing skills. And so this is a unique opportunity. We get some amazing volunteers locally. Some of them have been with us for over 10 years now. So the volunteers do 2/3 of the stories at Madison, and then the rest are done by staff like myself.
And how many VAs have this program?
We're at 80 VAs now.
Wow. How many VAs are there in the United States?
150 is the number that I have.
So you're more than half.
Yeah, it ebbs and flows, but I think that's a good estimate.
Wow. Huge impact. Bring us into the experience of collecting one of these stories. So let's say I'm a volunteer, I'm in the hospital, VA Madison, or wherever it might be, and I'm assigned to Mr. Jones, the patient in room 9. Walk me through the steps of how the story is collected, written, edited, and put into the chart.
Most of our inpatient interviews are done cold calling, we call it. So we go room to room, finding folks who are awake and bored and see if they're interested in telling their story. That's really our recruitment method. And I think Susan uses the same.
Yeah. Not being discharged that day and cognitively intact. That's it.
So that's the selection process. And that creates a kind of, there's an informality to it right from the beginning, which I kind of think is lovely, right? It's kind of kismet, it's like you're going to go into the room and you don't know who you're going to interview. You know little about them. And you just walk in and say, well, I'm here with this program and I want to talk to you about your life. We're going to write a story for you. People are like, what? Some people are like, yeah. Some people are like, yeah, what? Some people are like, no, get out. Other people are like, sit down. Other people are like, huh? So there's a really fun quality to it of just kind of saying, yeah, I'm here to talk, I'm going to turn it back to you, Susan, for the interviewing part. How do you feel the interviewing part goes?
Yeah, so the pitch, if you will, is that you don't have to talk about anything you don't want. It's not military focused. We'd never presume to get your whole story. That's impossible. About half the people say no, so it's not for everybody. How I coach the trainees is that it's almost like a non-interview interview in that there's no agenda. There's no question that needs to be answered. There's no check boxes. We're not going to get everything. And we're just here to receive whatever story that person wants to share on that day. I'll suggest maybe a first question. So let's begin at the beginning. Where'd you grow up and what was it like? Most of our interviews are in acute care, so people are so primed to tell their medical story. Sometimes you have to steer. And sometimes you only ask one question, and then the person tells you their life story. And the big thing that I frame is that it's more of an intensive listening exercise, and that by allowing the person the time, the story will unfold. We do not audio record any of the stories. It's note-taking, whether it's handwritten notes in a notepad or, typing notes on a laptop in the room. And then it's just from those notes then that the story is made. And there is some sort of crafting to it because it's not a transcript, it's a story. And some people tell their life story in a very, very linear fashion. And some people tell their story hither and thither. And some people will tell their life story and they actually won't talk about themselves at all. They'll talk about their brother or their father or flying plane. They'll talk about not themselves, but that's their story. And then we don't do any fact checking. It's not journalism. The other, I think, the writing coaching, which is an important thing, certainly with the trainees, because we're so used to writing in the third person. That's the biggest switch, is that writing in somebody else's voice can feel different and sometimes uncomfortable and sometimes nerve-wracking.
So I instead of he.
Exactly. And then the readback, while it's the shortest part of the activity often, it is a lot of times the most meaningful. And a lot of times the response when we offer this to the veteran, I'd say the most common response is, why would you want to talk to me? I'm boring. I'm sure there's someone more interesting or better. And then you read the story back, and now the person is laughing, or now they're crying, or they say, I'm going to take this home and I'm going to frame it and put it on my wall. But we've definitely had veterans who have asked the writer to sign the story, like by Susan. And then, the writer doesn't want, it's not my story. It's your story. I just wrote it down. And so, but that's happened more than once. So this idea of something really being made together.
Tell us about the readback. So they sit down, they collect the story. Do they go type it up and then print it and bring it back like same day? Or what's the turnover time and when does the readback happen?
As much as we can here, as soon as possible is ideal. I'd say the majority of ours get a same day readback just because the future is uncertain and people who are in the hospital, things change. When people are at home and then there's more of a back and forth, sometimes more time can lapse. But the farther you are from the initial interview, the less likelihood that that final readback and completion will occur.
I think it's great to get the readback done as quickly as possible. I'm such a crazy perfectionist that I take way too long on my story. So I end up like phoning people and reading them back over the phone more than I want to. But I would really agree with Susan that the readback is probably the most amazing part of it maybe for both. I can't decide, but there's something really surreal about reading a story, someone's story, back to them in their voice with your tongue and teeth and everything. It's just a very strange thing. And they're sitting there and you're like wondering, what are they going to like it? I mean, I think the choice of first person for me was really important because I feel like, and Susan spoke to this, it changes how it's interpreted and how it's done by the person. For me, at least, it really increases my sense of responsibility to get it right. Third person is just like, oh, this is my perception of the world. It's over here, da-da-da-da-da. Joe said this, Bob said that, But first person, you're really taking on a responsibility to represent somebody. And to me, that feels like big stakes. You want to do it right. And so I feel like there's sort of a built-in component to the process that just really urges people and kind of requires people to do the best job they can. And I think, like Susan said, the emotional reactions, for me, it's like when I repeat the veteran's favorite swear word, it's like always gets a big laugh because they're like, oh yeah, that's me, guaranteed. And then the sadness too. I mean, there's definitely really sad things, and it's just amazing sometimes to see how people cry as you read the story back. So it's very powerful.
After the readback, the veteran approves of the story to go in their medical chart. So tell us, where does it live in the chart, and how can clinicians see and click on and interact with the story like you did, Susan, when you saw that patient?
So for any VA providers out there, you might even have a My Life, My Story program at your VA and not know it, like I did. It's in the postings. So it's in that same place as things like advanced directives or allergies, life-sustaining treatment notes. The note title is just called My Story. So the whole idea and the hope is that even if you don't know what it is, much, again, like how I found it, you just see this note title and you click on it and it'll bring it up. So even if it was 1,000 notes ago or 3 years ago, you don't have to be digging to find it. I also just want to add another important piece is that it's only up to the discretion of the veteran whether or not it goes in the chart at all. And they can decide that they would like to do this, that they want the story for themselves, but they do not want it in the medical record. That's totally fine. So I suspect the numbers and the reach is probably greater, but there's a lot out there, and the veteran just didn't want it to go in the chart.
You said, Susan, that with your patient, you found the story, you read it, and it changed your approach to the patient. And I'm wondering if you could speak a bit to that. How does having this rich context, this, often I'm sure voicey, more relatable story in the chart, how does it change the way clinicians see and interact with and direct the medical care of veterans?
The content, even the story that you read, the content that comes out often really, really concretely can lead to very actionable clinical interventions. What are sources of strength that you've used in the past? How have you gotten through hard times? Things about family members that we didn't ask that very specific question that would get to that very specific answer. I've had a patient, he was being listed for an LVAD, and he had some early, self-directed early discharges. And by doing his story and then getting context around why he was doing those early discharges, it was very concrete, and he did actually ultimately get those therapies. So there's a lot of actionable content, commonly about trauma and PTSD and things about being in the hospital.
I could just add on to that just from not being a clinician myself, but just feedback from nurses and other folks who are on the units regularly. A couple times I've heard the stories of the difficult patient, and the difficult patient happens to have a story. And people read the story, and they understand why he's difficult. Not that he stops being difficult, but they have empathy for his difficulty because of what they read. And I've heard a couple times that's just changed the whole vibe on the floor around that person. So, it really can have an impact relationally, I think, in healthcare, and empathy can almost be a game changer in terms of connection and in terms of patients feeling like they matter and you matter.
Throughout your years doing this, do you have any favorite stories about the program? It could either be a memorable veteran or a memorable moment of a trainee or a nurse or somebody coming to you and saying how much the program meant to them on their end as the caregiver, or any other memorable moments related to this program.
I can start with a funny one that I love to share, because this is this just really touched me and really made me laugh. I read the wrong story back to a patient. I think I'm the only person to have done this that I know of. But what was funny about it wasn't just that I made the mistake, but just that he was so good-natured about it. He just let me go. And I'm sitting there reading the story, and I'm like, wow, he really likes it. He's smiling. He's got this big smile on his face. He's smiling because it's not his story. And, he waits till I get to the end after I've read my really emotional, powerful story. And he says, well, that's a really great story, but it's not mine. It was so funny. And I don't know why, but that experience sticks with me forever. Just because I don't know what. I felt like he was somebody who was telling me that our stories are all very close, actually. And anybody in the world is really only a half step away from us in terms of who they are as human beings. And when he said that really reminded me of that. It's it's close enough, it's a good story. It's not mine. But that's a funny one that I always think about.
I think one that's a little different is I had a veteran from the community who I didn't know. He wasn't patient, but he emailed our group, and he said that he's in a veteran peer support group, and that he heard about My Life, My Story from one of the veterans in his group who had done it, and that veteran said it was a good thing and that he should consider doing it. And I was so excited, and I emailed him very promptly with lots of materials, and I never heard back from him. But the fact that out in the community, that one person who did this told in his group, which is a safe group of people who trust each other, that he told that other person that this was a good thing. I thought that was pretty meaningful.
So what's next for the program? Any plans to spread to other institutions? Any plans to spread outside the VA system? Anything storytelling related that each of you individually are taking on as creative projects? Or what's next for the two of you in storytelling?
Well, Susan's leading the charge kind of outside the VA, I would say. You want to speak to that?
Sure. So because many of our trainees come from academic affiliates, and then they might come here on a rotation and they will do one interview, or they'll read an interview on a patient and they say, wow, this is a good idea. Can we bring this back to our home institution? So the answer is, of course, yes. None of this is proprietary in any way, shape, or form. And all we want to do is share it. And so we have an ever-growing network, and we do national meetings for education and sharing ideas and building community. And, more and more medical schools also are building this into the full curriculum. And so my hope is that maybe in 10 years, that this is incredibly boring and that this is just standard. And I think it could happen, but this is culture change. And so how long does it take to do that? It takes a while.
Yeah, and I think I'm sort of slowly strategic like you, Susan. It's like the long term is it's been about 12 years and we're at half the VA. So another 10 years, the goal is to have it easily available to every veteran in the system. And then outside of that, just having a way at some point to share the stories. We do have a book of veteran stories with accompanying photos that just came out last year. We're in the process of distributing those freely to libraries around the country, just so people, not even in the medical setting, but just outside, can get a different take on the veteran experience, the military experience, rather than the one that's presented to them in the media or in movies, because it's so limited and narrow. Actually, it's such a tiny sliver of what veterans really experience. And our goal, if anything, is to make sure that every story is completely different and written in a different way, done by a different interviewer of a different person's life. And so when you go into the chart to read it, you really don't know what to expect, which is kind of a lovely thing.
I have been speaking with the wonderful Dr. Susan Nathan, physician at the Boston VA, and Thor Ringler, therapist and poet in Madison, Wisconsin. Susan and Thor, thank you so much for coming on to talk about my life, my story, and for that beautiful reading at the top of the episode. So glad to have you.
Thank you.
Thanks,
it was
Emily.
an honor to be here.
This episode of The Nocturnist was produced by me and producer and head of story development, Molly Rose Williams. Our executive producer is Allie Block, and Ashley Pettit is our program director. Original theme music was composed by Yosef Monroe, and additional music comes from Blue Dot Sessions. The Nocturnist is made possible by the California Medical Association, a physician-led organization that works to ensure the doctor-patient relationship remains at the center of medicine. To learn more about the CMA, visit cmadocs.org. This episode of the Nocturnist Conversations is sponsored by the Physicians Foundation, which supports physician well-being, practice sustainability, and leadership in delivering high-quality, cost-efficient care. The Nocturnist is also made possible by donations from listeners like you. In fact, we recently moved over to Substack, which makes it easier than ever to support our work directly. By joining us with a donation of $2, $5, or $10 a month, you'll become an essential part of our creative community. I'm your host, Emily Silverman. See you next week.